Welcome back to ACCEL for August 2013. I'm Alfred Beauvais. Disc 2 begins with Dr. Al Waldo and Dr. Steven Swiryn, Professor of Clinical Medicine at Northwestern University and Adjunct Professor of Electrical Engineering and Computer Sciences. They discuss clinical implications of device-detected atrial tachyarrhythmias, results from the Registry of Atrial Tachycardias and Atrial Fibrillation Episodes in the Cardiac Rhythm Management Device Population, the RATE study.
Welcome, Steven.
Thank you, Al.
Tell us what RATE trial is all about.
Well, because we now have devices that are capable of recording preclinical or subclinical, depending on how you look at it, episodes of atrial fibrillation or tachycardia, we now have data that we aren't sure what to do with. And we know a number of interventions, including anticoagulation, to make in people with symptomatic episodes of atrial fibrillation. But the question is, what do these early episodes mean, if anything? And are particular kinds of episodes, long ones or short ones, more significant than others?
So what was the RATE study population?
So the RATE study population consisted of more than 5,200 patients recruited who got newly implanted defibrillators and pacemakers, and then were followed, and we kept track of two kinds of data. First, we kept track of the clinical events that they had, including hospitalizations, deaths, and specifically strokes, heart failure hospitalizations, and hospitalization for atrial fibrillation itself that was symptomatic. And then in addition to the clinical events, we also kept track of the electrogram events that showed the subclinical arrhythmias that they were having. The clinical events were adjudicated by a committee for that purpose. They were blinded to the electrogram results, and we had a very elaborate and careful adjudication of electrograms.
Tell us what you found.
We found that the incidence of atrial fibrillation or tachycardia in the device population, and it was similar in ICDs and pacemaker patients, was about 50% over 2 years. And that's similar to what some other studies have found. We found that when we divided the episodes into what we called short episodes, which we defined as episodes of an atrial tachyarrhythmia that the onset as well as the offset were both seen within a single electrogram, such as you might see in a routine clinic visit. That's called a short episode. And a long episode was defined as an episode where either the onset and or the offset of the atrial tachyarrhythmia was not visible within a single electrogram. And we often don't know with certainty how long that episode lasts. So it turns out that if you only have short episodes of atrial fibrillation, your risk didn't appear to be any higher for adverse events, either any adverse event or the individual adverse events, than the group without any episodes of atrial fibrillation at all. Whereas any single episode of a long atrial tachyarrhythmia put you in a group that was at higher risk for the total of all of the adverse events, and specifically hospitalization for symptomatic atrial fibrillation. And then we were able in the ICD group to look at the number of episodes, of long episodes of atrial fibrillation, and that in fact was a very, very strong predictor with an odds ratio of more than 10 and very highly significant of hospitalizations for symptomatic atrial fibrillation.
So the more long episodes you had, the more likely you were to have an adverse event.
In the ICD group, yes.
Now, can you say anything about the incidence of stroke and what you found and how this relates to the data?
The number of strokes, as has been found in a number of similar studies, was very small. We only had about 44 total strokes divided between the groups. The risk of stroke was not statistically higher in patients with long episodes of atrial fibrillation. There was a trend in that direction, but did not reach statistical significance.
And what about the timing of the fibrillation relative to the stroke?
That's a fascinating question, but unfortunately we haven't looked at that yet. But that's high on our list of things to look at. And of course it's quite fascinating. Showing the association doesn't necessarily show you an understanding of cause and effect. And the timing is going to be very interesting to see if these episodes of fibrillation occurred just before the stroke or not.
Now, did patients with long events also have short events? I mean, I'm getting to whether we know anything about progression of atrial fibrillation.
Yes, that's also going to be looked at. We haven't looked yet. We actually adjudicated carefully enough in this trial, which is a distinction from many other trials that have been done in this group of patients, where we'll know a lot of details about the atrial electrograms themselves, including atrial rate, morphology, and other things, and we'll be able to look at such things as progression over time as perhaps evidence of structural or electrical remodeling, and to see whether things changed. But we haven't looked at those data yet.
But from your data, we can say with confidence that only short episodes are, since they had no association with any, they were the same as having no episodes, that prognostically, this is an important finding.
Yes, so if you see an episode of atrial fibrillation or tachycardia that starts and stops within one recorded electrogram, and you never see longer episodes that go on beyond a single electrogram, that group has no more risk than people without any atrial tachyarrhythmia at all.
And that's not been previously recognized.
No, the other studies wouldn't have the capability to know that because they generally look at episodes only more than 5 or 6 minutes, depending on the particular study.
Any other aspects of the trial you'd like to share with us?
I think that the trial is very large in terms of total number of patients, with 5,200 patients, and we have a lot of adverse events. And I think there are a lot of interesting sub-studies that have the potential to come out of this, which we've been thinking through, and some of them we've started working on already. So I hope there will be a lot of excellent data to generate some good questions for clinical trials for the future from the rate registry trial.
Very good. So would you like to summarize the trial for us at its current stage?
Yeah, in summary, the rate registry has taught us, I think, that in a large group of patients with pacemakers and defibrillators, if you have long episodes of atrial fibrillation, you're more prone over time to have adverse events, including and especially hospitalization for symptomatic atrial fibrillation. And if you only have short episodes of atrial tachycardia or fibrillation that are confined within one electrogram, both onset and offset, you don't seem to be at any higher risk for adverse events than those with no atrial fibrillation documented at all.
Very good. And can I add one, perhaps?
Yes, please.
The incidence of these events, though, was remarkable. Essentially half the patients.
In a group with defibrillators and pacemakers, of course, they have a lot of disease accompanying them, and there were a lot of adverse events. Interestingly, 2 out of 3 adverse events occurred in the defibrillator group, even though only 2 out of 5 patients in the trial are defibrillator patients. So as you might expect, even though they're 8 or 9 years younger, they were the sicker group in terms of adverse events.
The point is how really common these things are and how important it is to understand their implications clinically.
Yes.
Stephen, there's one more point that's probably worth making, and that is about the care of the adjudication and the implications.
The vast majority of previous trials have adjudicated, if they adjudicated at all, only episodes lasting more than 5 or 6 minutes, depending on which trial it was, whereas we actually accepted any electrogram that the device thought was an atrial tachyarrhythmia. Matter of fact, any electrogram the device thought to record for any reason, and we looked at all of them. And because we did that, we have the ability to look at very short episodes that you commonly see in clinic and then have some sense of whether those have any clinical correspondence or not with adverse events.
This is one of the important things from this trial. We really will have, the first time, a really good handle on the meaning of these frequent and short episodes. They seem to be pretty benign at the moment.
Yes, I believe that they seem to be benign based on our results, and I think that's one of the nice strengths that comes out of the rate registry trial.
Stephen, thank you very much, and good luck with the rest of the trial.
Thank you, Al.